Uh, the topic is on evidence-based medicine. Now, I do remember the organizers were a little bit doubtful whether this would be the best topic for our target audience. I do not know. And besides, what is my claim to fame to talk on this topic? Well, possibly it could be because we started in an era where practice of medicine was, I would say, 80% experience-based and maybe 20% was evidence-based, whereas the pendulum has now swung. And now I think it's the other way around, 80-20, means 80% evidence-based, but still I think about 20% is still experience-based medicine that we practice. But the future generation may be looking at 100% evidence-based medicine. In which scenario, possibly, rather than be humans, maybe artificial intelligence will then be in a better position to guide our patients. So maybe that we have seen, our generation, myself would have seen this change in the practice. Maybe that gives me a right to talk a little bit about evidence-based medicine. Now, this does not mean that I am against evidence-based medicine. I hope that's not the conclusion that is taken back at the end of my talk. But I shall try and look at different facts related to evidence-based medicine. So with that, let's go into evidence-based medicine, but do remember at every point, please do consider the patient as a whole, not just individual packets of evidence. And when we talk of evidence-based medicine, we normally automatically associate that with clinical trial. Now, when did the first experiment, which was like a clinical trial, first happen? Was it 50 years back, 100 years back? No. If you look back, possibly the first documented something like a clinical trial, wouldn't call it a clinical trial, occurred around 500 BC. And it was by a person who's not a scientist, who's not a doctor, but a ruler of Babylon, Nebuchadnezzar. Now, he at one point during his reign ordered that all subjects should eat only meat and drink only wine. Now, there were some of the younger generation who were herbivorous, and they protested. Now, normally kings get angry and would say, no, nothing like it. What I have said is right. But this particular man was possibly intrigued, wanted to see what's there. And so what he allowed these people is to go on a diet with legumes and water only. Whereas his dictum in the past was you should have only meat and drink only wine. But they are supposed to come back to him after 10 days only, whatever the duration of the trial. You may maybe differ on the duration of the trial. And then he would reassess. And at the end of it, these young people came back, and according to his criteria, whatever, he felt that they were in better shape, better health than those who were the meat eaters. And so he allowed them to continue with this diet. So this is just a story that trials, trying to look at evidence, is something that we talk a lot about these days, but possibly it started several years back. However, it was this entire phenomenon was given a more definite shape by the US FDA's Kefauver-Harris's Act of 1962, or rather the amendment to their Federal Drugs and Cosmetic Act, which happened after the thalidomide tragedy, where we know thousands of children were born with congenital defects because the mothers took thalidomide to treat morning sickness in their early pregnancy. And this necessitated, at least in the US, that every drug company before they launch any drug should provide enough evidence of efficacy as well as safety, and also all advertisements or whatever the literature should have clear documentation of these. So that was 1962. So first was 500 BC, now 1962. But when we come to think of the term evidence-based medicine, this hallowed term, I think we can ascribe that to this gentleman, Gordon Guyatt, 1991. So still about 30 years, more than 30 years back. And why evidence-based medicine? I think there is a strong evidence, enough evidence that we need to have evidence in order to treat our patients properly. On the left, we see that there are several thousands of women at one time went through a grueling process, sometimes ending in fatality, of bone marrow transplantation for treatment of breast cancer, based on flawed research, flawed data. And on the right, if you think, it tells us that in the field of clinical medicine, quite often 2 + 2 does not automatically become 4. Now, what I mean is there is enough evidence that the class 1 antiarrhythmic agents definitely suppress cardiac arrhythmias, ventricular arrhythmias. And the other evidence is people following acute myocardial infarction quite often die because of arrhythmias. So people put 2 and 2 together and thought everyone after a myocardial infarction should have a class 1 antiarrhythmic agent prescribed, and this will reduce mortality after myocardial infarction. However, what happened was tens of thousands of people actually died, and the number of people dying because of inappropriate, indiscriminate, routine use of these class 1 antiarrhythmic agents after MI, actually the number was higher than those who died in the Vietnam War in that country. So there again, we need to have proper evidence, not just use a theoretical knowledge with some amount of evidence to decide that this should be in the best interest of the patient. But then how to interpret the results of evidence that comes out of clinical trials? It's sometimes tricky. And this is about aromatase inhibitors versus tamoxifen. Aromatase inhibitors block the synthesis of estrogen. Tamoxifen blocks the action of estrogen in early breast cancer. This is comparison of the two. Now, I don't need you to go into the details of this study, but if you find at the bottom, what we find that for years 0 to 4, during this trial, aromatase inhibitors looked better. But when you come to than tamoxifen, or when you came to year 5, it no longer had the edge over tamoxifen. So how do you manage these patients of early breast cancer? So do you use aromatase inhibitors for 4 years and then stop? Or because it should benefit over 4 years, should we not continue the same? So this is something that needs something beyond even the evidence. And so when we talk of evidence in evidence-based medicine, we always look at this hierarchy, and on the top, the pinnacle is RCT, or randomized controlled trial. But there are different other bodies of evidence as well. And at the very bottom is expert experience that I said possibly is what ruled our days, the initial days of practice of medicine. So RCTs versus expert evidence. And there is a system to look at evidence. There is GRADE, which looks at how to sort of to assess the reliability of the evidence. But we do need to remember that not all the data that we need can come only from a randomized controlled trial. For example, what about patients on dialysis. So do we stop dialysis in half the patients and continue dialysis in the other half, and then decide what are the end results? Similarly for hip replacement, similarly for diabetic ketoacidosis requiring insulin. So many a time we need also to depend upon observational study, which however has to be of sufficiently high quality. So it's not just randomized controlled trials which will give us an answer. And then about the limitations of evidence-based medicine, we all have heard the limitations of randomized controlled trials, that the trials have strict inclusion and exclusion criteria, so they may not represent the patients that you and I see every day in our clinics. Quite often, the elderly and women are underrepresented in clinical trials. And remember, at least 1/3 of all MIs, myocardial infarctions, occur in those above 75. But if you look at clinical trials related to MI, they account for only about 9% of the trial subjects. So real world evidence comes to be published, which would suggest that RCTs are possibly unreal. And we base many of our decisions on randomized controlled trials. The other issues are for most anti-diabetic drugs, anti-hypertensive drugs, we have clinical trial evidence for maybe for 5 years, if it's a long trial. However, we use these drugs for 20, 25, 30, 35 years. So do we have the evidence actually for usage beyond 5 years? We don't, but we do that. And that's again, using your maybe mental faculty and trying and extrapolating, which is nothing more or nothing grossly better than possibly so-called experience-based medicine. Then we have evidence for drugs in isolation, but many a time we use drugs in combination, both in hypertension and diabetes, and continue till long. So these are issues that we need to consider when we try and interpret the importance of evidence-based medicine. The other very important factor that we need to consider is the difference between statistical and clinical evidence. Now, we all think if p-value is less than 0.05, then it's magical, then it must be the final answer. But we do need to remember that what about p-value of 0.055 versus 0.045? So 0.055 will be rejected, 0.055 will be embraced, accepted. So in reality, I think the differences will not be so much, but for practical reasons, we need to draw a sort of cutoff line and say this is effective and this is not effective. And then there's the real issue of looking at evidence. Most pharma industry usually would like to make the data look very impressive to us, so they will highlight the relative risk, improvement in relative risk. So many times the absolute risk reduction may be 1%, 1.5%, 2.2%, whereas the relative risk reduction may be 35, 40, 50%. And that is what will be highlighted before us in order to make us accept a new form of treatment. But these are issues we should keep in mind. It's not to say that we don't look at the evidence, but try and make a proper balance of what you are looking at. Similarly, when we talk about statistics, we need to remember that many a time, for example, in any normal range that we think of, and here I have put before you the normal range of thyroxine in population. If you look at the laboratory reference range, it is quite broad. But for a given individual, the normal range could well be within very narrow limits. So these are, once again, the limitations of just using statistics and deciding that statistics rules everything. Possibly it does not, unless we really understand well. And then a little bit more about the limitations of evidence-based medicine, especially if we straight away from one study itself, we come to our conclusion. For example, the effect of spironolactone on morbidity and mortality in patients with severe heart failure way back in 1999, which showed that mineralocorticoid receptor antagonist like spironolactone could go a long way in reducing mortality, long-term improving not only the symptomatology, but also possibly improving longevity in patients with heart failure. However, and it was well accepted in various guidelines, but the paper to actually show the risk of hyperkalemia came much later in 2004, whereas the first paper was 1999. So we need sometimes got to take our final decision, maybe not immediately after publication of a paper, but maybe looking at different other papers as well. And then about use of low-dose aspirin. Now, in recent times, this has become less used in cardiovascular event prevention. And where we do find in terms of cardiovascular death reduction, aspirin versus noraspirin, there is a significant benefit. However, there is also increased risk of serious bleeds. So do we use aspirin in a given individual or not for cardiovascular risk reduction will depend not only on the cardiovascular risk factor, but also a whole host of other factors, including the risk of GI bleeds. And so will require consideration of the overall condition of the given individual. And then another limitation of evidence-based medicine is the bias of the easily measurable. We can measure weight, height, blood pressure, blood glucose, cholesterol, this and that. But objective data does not consider the less tangible, the quality of care, the patient's experience, so on and so forth, patient's wishes. And we also need to remember that ill health is not a binary phenomenon. It's not just the presence or absence. There could be so many shades of gray in between. So these are, again, possibly beyond the realms of evidence-based medicine. And then I come to a very important study, the Look Ahead study, which looked at the effects of intensive lifestyle intervention in type 2 diabetes for cardiovascular benefit. And it was decided at the end of 9.5 years of follow-up that this trial was stopped because it suggested no improvement of cardiovascular events in overweight or obese adults with type 2 diabetes. So this is widely taken as a negative study. What I'm trying to argue is, shall we consider that this is a negative study? Now, see, this led to weight loss. This led to improved biomarkers of glucose and lipid control, less sleep apnea, less liver fat, less depression, less urinary incontinence, reduced need for diabetes medications, better maintenance of physical mobility, improved quality of life, and lower costs. So quite often, while the pharma industry may want us to believe that it's statins only that can help, others are not of importance. I think it's important to look at the trial overall and not just maybe that's the primary endpoint was, of course, looking at cardiovascular events. But so many positives have emerged from this Look Ahead trial. And now I go to the opposite sort of spectrum of our conclusion from a clinical trial. So this is the direct study, which was published 3 years back by Michael Lean and his group. But we all know it was Sir Roy Taylor, who actually led this group, looking at primary care-led weight management for remission of type 2 diabetes, the direct study, and which showed that at 12 months, almost half the participants, actually 46%, achieved remission to non-diabetic state and off anti-diabetic drugs. And remission of type 2 diabetes is a practical target for primary care, was the conclusion. And remember, this is not a pharma company directed study, initiated study. This was by UK, Diabetes UK. And look at the response to this. Now, there are so many papers, including a narrative review of the evidence for reversal of type 2 diabetes. And now if you Google reversal of type 2 diabetes, you see at least a score of advertisements which will entice you to enter this program or that program for type 2 diabetes reversal. So do remember that the BMI that they looked at was clearly significant higher than many of our patients that come to our clinics. And the sustenance of weight loss is really difficult, at least in my personal experience over the last so many years. So other issues with evidence-based medicines would be medicalizing issues that are a natural accompaniment of life, like andropause. Quite often in trials, an inferior comparator, placebo, is compared to an active agent, and then misrepresenting small events as major breakthroughs. Finally, I would like to draw attention to the fact that evidence-based medicine itself, if you come to think of it, is not evidence-based in the sense that, have you ever compared that using one drug on the basis of evidence-based medicine and another drug not used based on EBM, is there a difference between the results? I don't think we have such sort of data. And then, please do remember, more than 10 years back, when this glargine insulin, this wonder drug, Alantus, came into our lives, we were taught that this is the true 24-hour insulin, without peak, absolutely flat action profile. And we have, all of us have parroted this in numerous meetings thereafter. Now, what happens after 10 years when the period of exclusivity comes to an end? You now have another glargine, which is U300, more concentrated, which now has taken the place of the original Lantus, which now says, this is now the real insulin that gives you 24 hours peakless profile. So either we were fools then, or we are fools now, or maybe we'll remain fools all through unless we look at evidence properly. And then quickly, I'd like to, we'll try and sort of come to the end of the talk. So now, once again, Canvas program is about one of the SGLT2 inhibitors, which did show that significantly, which was actually the only one amongst the three major SGLT2 inhibitor CVOTs, which showed that overall the primary 3-point MACE reduction was significant with canagliflozin. However, if you look at the data, you find while together death from CV events, non-fatal MI or non-fatal stroke was significantly reduced, individually, the drug did not significantly reduce either death from CV causes or non-fatal MI or non-fatal stroke. So this is about statistics. If you put these three together, then it becomes significant, but individually it does not decrease any of them, even statistically significantly. And then we need to remember that there can be negative trials. And so there can be reporting bias in medical research. 50% of research was never published. However, internationally it was recognized, and BMJ editorial, this was some time back in 2013, mandated that all trials must be registered and the results published. So this negative results being suppressed would possibly not happen these days. But I wish also to bring all of us aware of the tremendous force possibly of the pharma industry. Now, we all know of the Cochrane collaboration about serving us evidence-based medicine, set up in 1993. But not too long back, one of the actually founding members of Cochrane, Peter Goetze, from the Nordic Cochrane Center in Copenhagen, he made a lot of noise about interference by pharmaceutical industries. And possibly as a result, of course, I don't have inside information, he was voted out of the Cochrane committee because of his disruptive and inappropriate behaviors, which eventually, of course, also led to 4 other board members to resign. So clearly we have a strong pharma mafia, maybe. I'm sorry, forgive me for using strong words, which we also need to be aware of. We need to be aware of the requirements for a reliable research. It is there. And finally, as practicing physicians, do not be overawed that you need to keep track of so many different trials, evidence, and look at them so carefully. Second order peer review of medical literature for clinical practitioners can also be quite reliable. And so eventually, the clinician, the basic clinician may not need to read up each and every trial that comes, but we need to rely on reliable second order peer review. And so finally, ladies and gentlemen, I bring you to this fresco by Raphael in the Vatican, which has on the left the guru Plato with his finger pointing up towards heaven, whereas his pupil Aristotle has his palm turned down towards earth, sort of differentiating between the two approaches, or more practical approach of the newer generation Aristotle. As clinician, I think we need to keep our foot in both the camps and provide the best possible treatment, honest judgment for our patients. With this, I would like to thank all of you once again for providing me this opportunity. I'll stop sharing, and I do hope it made some sense to whoever cared to join. Thank you very much.
Thank you, sir.
Thank you, sir, for that mesmerizing talk. And of course, the word mafia today is very relevant, being a day of elections in the city. It was not out of place. Thank you, sir. And as this is an oration, I must acknowledge that this session was supported by USV, and oration does not, the talk is not followed by questions. Thank you, sir, so very much for being with us, for giving time in the morning during the inaugural session. And we can't thank you enough.